If you take a blood pressure pill every single morning, and millions of people over 60 do, let me ask you something simple. In the last year, have you felt more tired than you used to? Have you felt dizzy when you stood up too quickly? Have you had a cough that just wouldn't go away, one that your doctor couldn't quite explain? Have your legs felt heavy in the afternoon, like someone attached small weights to them overnight? Here is what almost nobody tells you. Every one of those things may not be a sign of aging. They may be a sign of your medication working exactly as it was designed to, but creating side effects that your doctor may have seen so many times that they no longer think to mention them. A quick and important note before we go any further. This channel exists to explain the why behind what's happening in your body. I am not a physician, and nothing you hear in this video is medical advice, a diagnosis, or a prescription. Please do not stop, switch, or change your blood pressure medication on your own. That can be genuinely dangerous. What I want you to do is understand what your body may be telling you, and then have an informed conversation with your doctor or pharmacist. That conversation could matter more than you think. Before we start, take a second and tell me in the comments, how long have you been on blood pressure medication? I read these, and your answer shapes what I cover next. Now, blood pressure medications are among the most prescribed drugs on the planet. In the United States alone, roughly 1 in 2 adults over 60 is taking at least one of them. And for many people, they are genuinely life-saving. They reduce the risk of stroke, heart attack, and kidney failure in ways that decades of solid research have confirmed. None of what follows is an argument against taking them. What this is about is a pattern that plays out in doctors' offices every single day. A patient, someone in their late 60s or 70s, comes in reporting fatigue, or dizziness, or muscle cramps, or a dry, persistent cough. And because those symptoms are so common in that age group, they are almost automatically filed under one heading: aging. The patient leaves without an answer, and the medication that may be driving the problem stays exactly the same. There are 4 classes of blood pressure drugs that are prescribed most often after 60. A diuretic, the water pill, a beta blocker, an ACE inhibitor, and a calcium channel blocker. Most people on blood pressure medication are on at least one of these. Many are on 2 or 3 combined. And each one, by the very mechanism that makes it work, can produce a distinct set of side effects that look, on the surface, exactly like getting older. That is what we are going to walk through today. Not to frighten you, not to tell you to stop anything, but to give you the information your rushed 12-minute appointment may never have. Let's start with the water pill, the diuretic. Hydrochlorothiazide and chlorthalidone are the names you'll see most often, though furosemide is also widely used. These are often the first medication a doctor reaches for when blood pressure is elevated. They work by telling your kidneys to push more sodium and water out of the body, reducing the fluid volume in your blood vessels, which lowers the pressure against the walls. The mechanism is straightforward and effective, but here is what the mechanism also does. When your kidneys excrete more sodium, they often take other electrolytes with it: potassium, magnesium, and in the case of thiazide diuretics specifically, they can disturb sodium balance in ways that go in the wrong direction in older adults. The result is a condition called hyponatremia, low sodium in the blood. Think of your blood sodium like the salt in a fish tank. The fish, your cells, need that concentration to stay at a precise level to function. When it drops, every cell in the body is affected. Your muscles feel weak. Your brain feels foggy. You feel tired in a way that sleep doesn't fix, and you are at a significantly higher risk of falling. This is not a theoretical concern. Research published in BMC Geriatrics followed patients aged 75 and older admitted to an emergency geriatric unit and found that mild hyponatremia was present in roughly 1 in 6 of the patients, and that those patients were about 3 times more likely to have been admitted due to a fall. A separate study found that among elderly patients with hyponatremia from a fall injury, mortality was 2.5 times higher compared to those with normal sodium levels. The symptoms of low sodium come on slowly enough that they are almost impossible to separate from everyday tiredness: fatigue, mild confusion, muscle cramps, headache, nausea. In older adults, they often show up as what looks like simply having a bad week. If you are on a diuretic and have noticed any of those things, especially leg cramps or a foggy feeling in the mornings or dizziness that you can't quite account for, the single most useful thing you can do is ask your doctor to check a basic metabolic panel, a blood test that takes 5 minutes to order and can show your sodium, potassium, and kidney function at a glance. That is the conversation worth having. Never stop a diuretic on your own. In some people with heart failure or kidney conditions, stopping can cause a dangerous fluid buildup within days. The point is monitoring, not stopping. The second drug class is the beta blocker. Metoprolol, atenolol, carvedilol. These are among the most commonly prescribed drugs in the world. They work by blocking the effect of adrenaline on the heart, slowing the heart rate, and reducing the force with which the heart pumps. Less force, less pressure in the arteries. The logic is clean, but your heart rate is not just a blood pressure number. It is also your body's way of responding to effort. When you climb a flight of stairs, your heart speeds up to deliver more oxygen to your muscles. When you hurry across a parking lot, the same thing happens. Beta blockers put a ceiling on that response. They don't just lower your resting heart rate, they lower your maximum heart rate during any kind of physical activity. Imagine your heart like an engine with a governor installed. A device that caps the RPM no matter how hard you press the accelerator. You can still move, you can still function, but at higher efforts, the engine cannot respond the way it used to. What that feels like from the inside is fatigue that arrives earlier than expected. You feel tired doing things that didn't tire you before. You may feel short of breath on exertion, not because your lungs have failed, but because your heart cannot speed up enough to meet the demand. Beyond fatigue, beta blockers can cause cold hands and feet because they also reduce circulation to the extremities. Some people on beta blockers notice a change in sleep, or a low mood, or a reduced sense of energy that sits just below the threshold of what they'd call depression. These are well-documented, well-recognized side effects. They are also the ones most commonly attributed to simply getting older. StatPearls, the clinical reference published through the NIH, notes that fatigue and cold extremities are among the recognized adverse effects of beta blockers, and that some patients experience weight gain and reduced exercise tolerance. These are not surprises in the medical literature. They are just surprises to the patient who was never told. If you are on a beta blocker and you have felt persistently tired, not depressed, not sick, just drained in a way that doesn't fully lift, this is worth discussing. There are different types of beta blockers, and some are better tolerated than others. There are also cases where, after a review, a doctor may determine that a different class of medication fits better for a particular person's profile. That is a clinical decision. But it starts with knowing that what you're feeling may not be your age. Now let's talk about the cough. If you are on an ACE inhibitor, lisinopril, enalapril, ramipril, or any drug that ends in pril, and you have had a dry, persistent, tickling cough for months, there's a good chance you already know what is coming. ACE inhibitors work by blocking an enzyme called angiotensin-converting enzyme, which normally produces a chemical that tightens blood vessels. Block that enzyme, the vessels relax, the pressure drops. The mechanism is elegant and effective. But ACE also breaks down a molecule called bradykinin. When ACE is blocked, bradykinin accumulates in the throat and airways. It is an inflammatory signal, and when it builds up, it irritates the airways in a way that triggers a dry, non-productive cough. No mucus, no infection. Just a persistent tickle that makes you clear your throat constantly, that wakes you at night, that people assume must be reflux or allergies or postnasal drip. This is not rare. The cough associated with ACE inhibitors affects somewhere between 5 and 35% of people who take them, a range that reflects individual variation, with women and some ethnic groups affected more than others. In UK Biobank data analyzed in a large genetic study, the overall prevalence of ACE inhibitor-induced cough was around 13 to 15% of users. Here is the thing that matters most. The cough is not dangerous. It is not a sign of something going wrong with your lungs. It is a pharmacological side effect, and it is completely reversible when the medication is stopped or switched. The clinical guidelines for this are actually quite clear. Doctors are recommended to switch patients with intolerable ACE inhibitor cough to an ARB, a closely related class of drug that lowers blood pressure through a similar but slightly different mechanism and does not cause the cough. If you have had this cough for months and accepted it as part of your life, please bring it up at your next appointment. Tell your doctor specifically, "I think this may be my lisinopril." That one sentence can get you an answer and potentially a solution the same day. There is one more thing worth mentioning about ACE inhibitors. A very rare but serious side effect is called angioedema, a sudden swelling of the lips, tongue, throat, or face. This is not the same as the cough. This is an emergency. If you are on an ACE inhibitor and you experience sudden swelling in or around your face or throat, call emergency services immediately. It can block the airway within minutes. The cough is a nuisance. Angioedema is an emergency. Know the difference. The fourth class is calcium channel blockers. Amlodipine is the most commonly prescribed one in this country. Diltiazem and nifedipine are also widely used. They work by blocking the movement of calcium into the muscle cells of the artery walls, which causes those walls to relax. Wider arteries mean lower pressure. The most common side effect of calcium channel blockers, and it is genuinely common, is ankle and leg swelling. Medically, it's called peripheral edema, and it happens because as the arteries relax and widen, the change in fluid pressure can push fluid out of the vessels and into the surrounding tissue. The fluid pools in the legs, especially by the end of the day. You take your socks off, and there are indentations in your ankles. Your shoes feel tight by the afternoon. In a study that reviewed real-world adverse events in patients on common blood pressure medications, ankle swelling from calcium channel blockers was reported in roughly 27% of patients, making it one of the most prevalent medication side effects in the entire category. The critical point here is this. Leg swelling has a long list of possible causes. Heart failure is one of them, and heart failure is serious. A doctor looking at a patient with leg swelling needs to know whether it appeared before the medication started, whether it appeared at the same time, or whether it has been there for years and no one connected it. If your swelling started after you began a calcium channel blocker, that is important clinical information. If it appeared recently and independently, that needs investigation. Calcium channel blockers can also cause flushing, headaches, and in some people a fast or pounding heartbeat, particularly in the first few weeks. These usually settle, but a persistent heartbeat change is worth mentioning to your doctor. So here is the pattern, stated plainly. Fatigue, dizziness, muscle cramps, mental fog, these can be diuretic side effects, or signs of low sodium or low potassium. Persistent tiredness, cold extremities, exercise intolerance, these can be beta blocker effects. A dry, tickling cough that won't quit, ACE inhibitor. Ankle swelling by the end of the day, calcium channel blocker. None of these automatically mean your medication is wrong for you. Some of these side effects are a reasonable trade-off for the protection the medication provides. The goal isn't to make you doubt your prescription. It is to give you enough information to have a real conversation instead of walking out of an office with a symptom that's been labeled as aging. Consider someone in her early 70s, call her Eleanor, who had been on lisinopril and hydrochlorothiazide for 4 years. She came in to see her doctor for fatigue and was told it was probably her thyroid. The thyroid came back normal. She was told it was probably sleep. She bought her new mattress. The fatigue continued. It wasn't until she mentioned, almost as an afterthought, that she also had a dry cough that kept her awake, that a pharmacist reviewing her chart suggested checking her sodium and discussing the cough with her prescribing physician. Her sodium came back low normal. Her lisinopril was switched to an ARB. Within 6 weeks, the cough was gone. Within 2 months, she described feeling more energy than she'd had in years. This is an illustrative example of the kind of case that plays out regularly in geriatric medicine. Not a miracle, not a reversal of aging, just a medication review that should have happened sooner. Here is what tonight's plan looks like if any of this resonated. First, write down your symptoms. Not vaguely, specifically. When do you feel tired? What time of day does the dizziness happen? When did the cough start? How long has the swelling been there? Specific symptoms give a doctor something to work with. Second, write down every medication you take, including the dose and the time of day you take it. Bring that list to your next appointment. A surprising number of people are taking duplicate drugs from different prescribers. Third, Ask your doctor, not am I okay, but could any of my blood pressure medications be causing my symptoms? That specific question gets a specific answer. Fourth, if you are on a diuretic, ask whether a basic metabolic panel to check your sodium and potassium is overdue. If it has been more than a year since anyone checked those numbers, that is a reasonable request. Fifth, if you have a cough you have been living with for months, tell your doctor which medication you are on and ask directly whether it could be the cause. And the most important thing I will say today, and I will say it clearly so it lands, do not stop, skip, or have your blood pressure medication on your own. The risks of uncontrolled blood pressure, stroke, heart attack, kidney damage are real and they can happen quickly. The goal is a medication that works for you without unnecessary suffering, not no medication at all. That is a conversation. Have it. If this helped you see something differently today, if it gave you a question you didn't have before, tell me which symptom resonated most in the comments below. That tells me what to cover next. And if someone you care about is on blood pressure medication and has been chalking up their tiredness or their cough to aging, share this with them. One conversation with a pharmacist can sometimes change years of unnecessary symptoms. There's a video on this channel that goes deeper into what happens to your kidneys specifically when you've been on blood pressure medication for more than 5 years. And the one test that most seniors over 70 should be getting annually, but often aren't. That one is worth watching next. Take good care of yourself. You are not stuck with side effects you were never told about.